medical officer to the Navy SEALs, isn't with us early. It's an unusual day, but I don't see that we have our folks populated yet, so we should just take a moment to review that. David, what I'll be doing now is going through just a handful of slides, and then I will hand the meeting off to you unless Scott Flynn has joined us. And thank you so much for your willingness to do that based on already knowing Marcia. So we have 40 participants now with us, many of whom don't know the Right Care Initiative yet. So I just want to welcome our amazing leadership team and people from all around California as well as nationally. And we even have a smattering of international participation today, which is very exciting. The Right Care Initiative started 15 years ago, and we've hosted over 312 public meetings sharing best practices, many of which include continuing medical education, and that will be available today. And I need to have you, Jenny, remove Albert's email from this front slide because he's not able to be with us today. We're just doing a little bit of changes. So if anybody has any questions today that need staff attention, look at the chat, which is to please contact rightcare@berkeley.edu. So we will move quickly into the session because we've got fantastic material to cover. I just want to thank all of our amazing sponsors, the State of California, UC Berkeley School of Public Health, which is our mothership. We have lovely support from the American Society of Preventive Cardiology, who's with us co-leading this meeting today, as well as our biopharmaceutical supporters and members, and the California chapter of the ACC. Thank you across the UCs, Stanford, USC, also for being such strong partners here. Next slide, please. Most of you know me by now, but for those who don't, I've worked in clinical quality improvement for a couple of decades now. It's what I studied at the Kennedy School of Government at Harvard, and also as an undergrad at UC Davis. I work at UC Berkeley School of Public Health, running the Right Care Initiative with all these wonderful volunteers. Next slide, please. So I want to ground this meeting in this wonderful new data out of the Centers for Disease Control, which shows us that in the United States, already in the 35 to 44 year age group, contrary to popular belief, the cancers for which people are standardly screened are killing fewer people than the cardiovascular diseases that we focus on, hypertension, heart attacks, and strokes primarily. And it's much worse for men than women. And we're going to learn some things today that are going to change that. And we're working very hard to reduce these deaths collaboratively across the state and increasingly the nation. Next slide, please. Next slide, please. Dr. Flynn was expecting to be with us today, and he was going to run through these slides, but I'm certainly just thrilled to relay to you all that we've been running we started 4 University of Best Practices across the state of California, all of which have been focused on hypertension, cholesterol, blood sugar, and teaching best practices for that. Next slide, please. We use data to show the health systems how their performance is, and we work very hard to improve those numbers. I have to give great credit to Dr. Bill Baumer for the wonderful high consistent performance on blood pressure control, which came about with his amazing teaching skills in the Sacramento area. We have now gone to be fully virtual, so the physicians and other clinical leaders and quality improvement experts across the state are now getting to know each other across the 4 regions that we built. Next slide, please. We basically teach the same thing in different ways. So we're going to learn today about what's in the bottom right corner, nationally endorsed guidelines on chest pain. And we're going to learn about some really exciting news out of Denmark on the use of coronary artery calcium screening to reduce these deaths. Next slide, please. The first hour will be on the chest pain guidelines, and the second hour will be on coronary artery calcium and other screenings being used in Denmark. Next slide, please. Now I'm going to hand the meeting to the wonderful Dr. David Maron, the head of preventive cardiology for Stanford, who will lead the introduction of our first amazing speaker. Thank you, David.
Thank you, Hattie. You will notice I have a bandage on my nose, and now forget about it. It's the aftermath of some Mohs surgery, and I need to learn a little bit more about prevention of skin cancer. So it's my pleasure to introduce Dr. Mathew Gulati, a friend and colleague. She's the Director of Prevention and Associate Director of the Barbara Streisand Women's Heart Center at Cedars-Sinai. And she's currently the President of the American Society for Preventive Cardiology. She chaired the writing committee for the American College of Cardiology, American Heart Association chest pain guidelines. And she's going to talk with us about that today. Welcome, Martha.
Thank you. Thank you for having me. And let me just pull up my slides here and get started. Can everyone see my slides? I'll just look for, yeah, great. So I'm going to talk about the chest pain guidelines. That's what specifically this group wanted to hear about. And I'm going to present them sort of the way that we presented them to the world, with our top messages, because of course, guidelines are quite thick and extensive. And of course, we think every word we put in there has important meanings, but we try to also boil it down to a meaningful way for people to use them in practice and for the public to also understand what the most important things in these guidelines are. So I'll start by saying I have no disclosures, and I always start with a little bit of history. So, you know, chest pain is so common, and yet it really, in terms of it documented, for somebody documenting the way that somebody would experience angina or reduced blood flow to the heart, the first time we have a documentation of that is from 1772, where Herberden describes it. And you'll see like his very vivid description is here. He says, those who are afflicted with it are seized while they're walking, most especially if it be uphill or after eating, with a painful and most disagreeable sensation in the breast, which seems as if it would extinguish life if it were to increase or to continue. But the moment they stand still, all this uneasiness vanishes. And then he goes on to describe it further, saying that for if no accident interferes, but the disease goes on to its full height, the patients all suddenly fall down and perish almost immediately. And of course, in 1772, that was probably very true, because what medical treatment did we have when it was ischemic heart disease, when there was disease of the heart? But of course, chest pain is more than just being related to the heart, and that we were tasked with this huge undertaking to describe to people the workup for chest pain, which is, you know, quite complicated. And chest pain is incredibly common. In the United States, it accounts for 6.5 million emergency visits and about 4 million office visits. And of course, in the emergency room, we're trying to determine, is it life-threatening? And of course, we're always trying to tease out acute chest pain from stable chest pain. Acute chest pain tends to be mostly what we see in the emergency room, but not always. But when we look at what we end up diagnosing in our emergency rooms, you can see over here this excellent paper that came from UCSF, in fact, showed that the most common diagnosis people leave with is non-specific chest pain. The blue is non-specific chest pain. And as people age, there's more likely to develop coronary atherosclerosis or to have an acute myocardial infarction and congestive heart failure and other cardiac causes, but it isn't always cardiac, right? Pneumonia can cause chest pain. Abdominal pain can sometimes mimic chest pain. So it's, again, very few people, but we don't want to miss the things that are life-threatening. That is really the priority. Is the first thing with chest pain is to identify the life-threatening causes. So acute coronary syndrome, aortic dissection, pulmonary embolism, or even some important non-vascular syndromes, things like esophageal rupture, we don't want to miss. And there's characteristics of someone's history that points in the direction of it might be one of these many things. So the history is still important. And when we talk with our patients, we want to know all the characteristics of the chest pain. And obviously, as a cardiologist, I'm trying to tease out if it's cardiac in nature. And again, there's specific symptoms that point to it being cardiac in nature, but there's no one way of describing chest pain that is perfectly diagnosable, that this is your heart versus this being something else. So again, it's the art and science of medicine. But again, acute coronary syndrome, pulmonary embolism, aortic dissection, esophageal rupture, those are the life-threatening causes. But of course, there's other causes that can mimic these. And it's important for us to really tease that out. So again, I told you I'd frame this in the top 10 messages, and we made a funny acronym called chest pains, hoping people would remember this. So let's go through these one by one. So first of all, we wanted to point out that chest pain is more than pain in the chest. And in fact, when we were tasked with the idea of writing chest pain guidelines, most of our writing group said, but it's not always chest pain. I mean, how can we use that word? We know patients use different words. And so what we did is we said that there's a probability of ischemia. There's no one perfect symptom, but some symptoms are more likely to be cardiac in nature, particularly ischemic in nature, and some are less likely. And so taking a history will matter for us to get the idea of what is the probability of this person's symptoms being cardiac or being ischemic versus not being ischemic. And of course, it's a class 1 recommendation that the initial assessment is to triage our patients based on the likelihood that the symptoms they're experiencing are myocardial ischemia. Now, it is true, sometimes it's very clear there's another cause. You don't all take care of vampires, but if you do, you know that they're clearly, you can tell the cause of this person's chest pain. Also in these guidelines, we wanted to highlight groups that had been often dismissed or underdiagnosed. And so those 3 groups are women, elderly, and people of ethnically diverse population backgrounds. So women I'll talk about a little bit later, so let's just skip over them for this time. But elderly patients, for patients over the age of 75, we should think about cardiac disease, especially acute coronary syndrome. As we age, cardiovascular disease is more likely, but especially with patients who have an unexplained fall. If you don't have an underlying cause for that, you might think about myocardial ischemia, and we shouldn't miss them. Now, for ethnically diverse populations, we gave a class 1 recommendation that we think physicians and the healthcare community needs to be trained in cultural competency, because our populations are getting more diverse with patients of diverse racial and ethnic backgrounds, and they often can present with chest pain. So we need a workforce that is able to address the population that they serve. And we also made a class 1 recommendation that using formal translation services for people whose first language is not English is important, because I think that getting the characteristics of somebody's description of what they're experiencing is so important to doing the next steps and deciding whether you think this could be cardiac or it could be something else. Our next letter stands for the high sensitivity troponins, and high sensitivity troponins now are pretty much the main biomarker that is used, and we said that they are preferred. Now, troponins in general are preferred. If a hospital isn't using high sensitivity troponins, it's still a class 1 recommendation just to use troponins, but our preferred troponin is the high sensitivity cardiac troponin. What we can't say is that every hospital's values are the same. And really, clinicians need to be familiar with their 99% upper reference, because that is how it will be for your hospital. And even the hospital across the street from you will have a different cutoff. So it's important for you to know your thresholds. And then additionally, you know, some hospitals are using sex-specific cutoffs, some are not. You need to know what your hospital has decided, and it's been rolled out over the last few years throughout the United States, and now the majority of them are using high sensitivity troponins. In the same light, we gave a class 3 or no benefit to CKMB isoenzymes or myoglobin, things that were used in the past that are not as helpful as cardiac troponins. Now, of course, we gave one of our most important messages is that patients should seek care early for acute symptoms, but not just the patients, but even when we're caring for these patients in our office settings, we want to be quick about patients who present with chest pain. So it's a class 1 recommendation that when patients are being seen in the office setting and they are experiencing acute chest pain, they should be transported emergently to the emergency department, ideally by EMS. And unless there's a non-cardiac cause that's evident, then an EKG should be performed. But if an EKG is not easily accessible in the office setting, then you still want to get them to an emergency room. We don't want to delay care. Of course, time is heart muscle. So it's class 3 to have a delay, in fact, harmful to delay waiting for cardiac troponins or other testing. That should happen in the emergency department. That should not be happening in our office settings. And also, we were asked to address how quickly things should be done. And so we did give a recommendation that on arrival to the emergency department, when someone is experiencing acute chest pain, then EKG should be acquired and reviewed within 10 minutes of arrival. And that's specifically because if they are having an ST elevation myocardial infarction, we should initiate treatment very quickly once we know that. And we'll only know that if we see them quickly and perform an EKG. And of course, we do recommend that cardiac troponin should be measured quickly, but we don't really have data to say the timing of that, because often if the EKG makes the diagnosis, you may not even have to wait for a cardiac troponin. They may already be in the cath lab. So again, EKG is a key component of cardiac workup when someone presents with chest pain, because of course we can diagnose ST elevation myocardial infarction and follow those guidelines. If we diagnose pericarditis, then we can manage that. If we see new T wave or ST changes, we might follow the non-ST elevation acute coronary syndrome guidelines. And if it's non-diagnostic, we might decide to repeat an EKG, or we might decide to do a reverse lead EKG. But an EKG may also diagnose an arrhythmia, and that may be the underlying cause of their chest pain. So again, this is why the EKG is still central to everything that we do. And so is the chest x-ray. So chest x-ray is a class 1 recommendation, and we strongly feel a chest x-ray will be useful to identify not just cardiac causes, but pulmonary causes and thoracic causes of someone's symptoms. Now, our next recommendation is about sharing the decision-making. And shared decision-making is something that we talk about a lot in our cardiology guidelines, but I think what makes our guidelines a little unique is that we actually have randomized controlled trials about shared decision-making, which really is why we could give a class 1 recommendation and clearly state that when patients present with acute chest pain who are low risk using a clinical decision pathway, those patient decision aids can be beneficial to improve the patient's understanding and effectively facilitate risk communication. Dr. Eric Hess was one of the co-authors on our guidelines, and he led a lot of this work. And what he did is you created a shared decision-making tool, and in low-risk patients, helped them understand their risk. Those patients who were in the shared decision-making arm chose not to have additional testing more often than those in the usual care. So it's obviously saving our system money if you use a shared decision-making tool. And those patients didn't do worse. So just by not doing additional testing in them didn't mean that they did worse than the people who got more testing in the emergency room. So it's incumbent on us to use shared decision-making tools in the emergency room for these low-risk patients, the patients that we know don't need additional testing, but you also have this patient who you have to communicate effectively with them so that they understand and agree with you. Because obviously, when people experience chest pain, they're scared that something might be going on with their heart. Now, this is the shared decision-making tool that Dr. Hess's group created, and it's available, and there's a link within the guidelines, communicating with patients not by percents. They don't understand percents, most people, but saying that, out of 100 people, 2 people experience this, that's a way to communicate. So using these tools effectively in our emergency department may help us clear out our emergency departments, not have to do all the testing there. It could be deferred testing. They still might need testing, but they may not need it in the emergency room. And of course, during our pandemic, we saw just how valuable our emergency beds are, and to really move our patients effectively, I think should be of great importance. And that comes to our next recommendation, that testing is not routinely needed in low-risk patients. First, we define what is low risk, and low risk is what has been used by a lot of these clinical decision pathways, but patients who present with acute chest pain and their 30-day risk of a major adverse cardiovascular event or death being less than 1%, that's what we mean by low risk. And so we should be using that terminology consistently. Now, the next recommendation is to use the clinical decision pathways, and you'll see those in our guidelines that we recommend, that clinical decision pathways after you get troponins. That is how you stratify a patient's risk to whether they're low, intermediate, or high risk, and that obviously has different implications. I already said that for low risk, we might decide not to do any additional testing. High risk, you might go straight to the cath lab. Intermediate risk is the more interesting group that you need to decide what to do with these patients. But clinical decision pathways have had a lot of different names. We've called them accelerated diagnostic protocols. We've called them disposition pathways. So we unified the terminology and just call it now clinical decision pathways. And so when we know what our emergency room is using when they phone a cardiologist, we hopefully are all speaking the same language. Now, clinical decision pathways, there's many of them out there. We didn't endorse one over another because there's no particular data to support one over the other. In the United States, we tend to use the heart pathway more than the others. But again, you should know what your hospital uses, what your emergency room uses, so that we can all communicate effectively and know what each other is talking about. So if somebody calls us and says, this patient is intermediate risk, you don't have to question about why are they calling me. Of course they're calling you. They want some guidance about what should they do next. Maybe if they've already determined they're high risk or low risk, they've already got that covered. So I think that really will help us more effectively communicate as a healthcare community. Again, the low-risk patients allow us to potentially defer testing and discharge our patients. Now, I did promise to come back to women, and there's 2 very important recommendations in our guidelines specific to women, one on this page, well, actually 2 on this page and then 2 a little bit later. But one of our top 10 messages is to understand the similarities and the differences between men and women. And particularly for women, women actually experience chest pain as often as men. In fact, in our contemporary literature, 90% of women will report chest pain or chest discomfort. The difference, though, between men and women is that women report additional symptoms or accompanying symptoms. 3 or more, in fact, tends to be quite commonly seen in women. And chest pain may only be a small part of what they're experiencing, so much so that it won't even be the first thing necessarily that they say. They might say it first, but they might not. So the most important thing is to understand that women are at risk for heart disease, and women who present with chest pain, we should know that they are underdiagnosed, and you should always consider potential cardiac causes when you see a woman with chest pain, just the same way that we do with men. But with women also, it's a class 1 recommendation to obtain a history that emphasizes those accompanying symptoms, which are more common in women who present with acute coronary syndrome. Again, we hope by these recommendations that we will have more timely and appropriate care of women and really narrow the gap that persists no matter how much we've been talking about this for 2 decades, about the undertreatment and underdiagnosis of women. We really need to do better when it's in the setting of an acute coronary syndrome. Now, our next recommendation is about identifying patients most likely to benefit from further testing. And this is really the intermediate risk group. That's true whether we're talking about acute chest pain or whether we're talking about stable chest pain. We have different pathways for them, and we've given different options. So I like to talk about the 2 options for testing when you're intermediate risk as either anatomic or functional. Functional testing, where we do imaging simultaneously with either exercise or pharmacologic stress testing, where we can get the cardiac anatomy at the same time to understand what's going on. And that is an option and a class 1 recommendation, but so is anatomic testing. And that this is really new to these guidelines, that coronary CTA can be used as well to see anatomic disease. And it's been shown to be equally as good. So depending on what one is available in your emergency room or where your expertise at your hospital is, we now have given everyone the option to use either. And the same is true for stable chest pain. Perhaps the one thing that changed in our guidelines compared to the stable ischemic heart disease guidelines is that actually exercise EKG kind of got a downgrade, and all our other imaging modalities got an upgrade. Again, anatomic versus functional testing. You can still use exercise EKG. It's a 2A recommendation in stable chest pain, but we recognize the limitations of not being able to either see anatomic disease or to have evidence of ischemia from functional testing. So again, another way to put it all together, we don't want to test patients who are symptomatic. We don't believe we need to test low-risk patients, at least in the emergency room setting. You might want to do things as an outpatient to better risk stratify them, and certainly that is an option that we touch on in the guidelines. But the group that, again, is the most interesting one is the intermediate risk group, where we don't know and we want to use different forms of testing. Obviously, when it's acute chest pain with where we know they have an acute coronary syndrome, that's a very different thing, or a high-risk patient where you'll take them right to the cath lab. Now, one of the questions that I think a lot of people ask is, does my patient in front of me need further testing? And when we look at contemporary literature, we know that we do a lot of testing in the United States, perhaps in people that don't always need testing. When you look at the risk of the patients who have stable ischemic heart disease, many of them are low risk or intermediate risk. Very few are considered high risk, actually. Until they age, they really don't become high risk, just based on the population that we're testing now. Compared to 2 decades ago, we were doing probably on a higher risk group, that many patients who went to a cath lab, that was a very different population than what we're seeing now. So it's just important to understand who we're testing right now. Now, again, do you want to use CCTA or anatomic testing versus functional testing? Well, like I told you, it's a class 1 recommendation. that you can use either. We have more contemporary literature about CCTA now, and that's really why it got a higher grade, class 1A recommendation. But either of these is right. It just depends on the patient in front of you. And we say that, again, CCTA may be preferable in those people under the age of 65, and functional testing may be preferred in those over the age of 65 in patients that you know will have a higher likelihood of ischemia. Again, there might be other reasons, that you might use CCTA, again, based on your institution, availability, that obviously an expertise will matter. If you've ever had a prior test inconclusive that was a functional test, you might use an anatomic test and vice versa. So again, depends on the information that you need, why you would choose one test over another, but all the options are available to you. So again, local availability and expertise, certain characteristics of our patients and contraindications. Of course, shared decision-making is encouraged because patients may have fear of one type of test versus another, or they just prefer a specific test. I think when you use functional testing, you should think about using exercise if that's an option, because I think that that is a better test overall. And if you have PET, and you also have SPECT, we say that their PET is actually preferred, that there's higher quality images. So again, you can decide these things based on the individual in front of you, and there's different information that you will get depending on what you use. Now, people asked us, tell us about cost in these guidelines, which was really a big challenge for us, because when you look at the studies done, the studies that get published are always studying their imaging modality to something that they're almost guaranteed a win at. For example, CCTA, when you compare it to going to the cath lab, of course it's cost effective. If you look at exercise EKG, of course it's more cost effective than using other imaging, but how many tests might you get downstream as a result of that? Same with all the imaging modalities. It depended on what they were comparing to, but all of them that get published were positive studies saying their imaging modality was more favorable if it was used. So it was hard to say that there's one most cost-effective test. And I think that until somebody compares everything head to head, we won't be able to say that. In addition, I think that considerations about imaging, need to be taken about specifically of women of childbearing ages, but specifically in women who are pregnant or postpartum. In everyone, we want to use the lowest effective dose of radiation, but this is obviously of greater importance in a woman who is pregnant. And you should consider alternative tests like ultrasound or cardiac MRI in these situations. But of course, depending on what the situation is, you have to always weigh if the risk versus benefit validates the reason why you need to use something that involves radiation in a woman who is pregnant. Now, our next top message is that non-cardiac is in and atypical is out. And what does that mean? Well, we have described chest pain, particularly in women, as atypical chest pain. Very, very frequently you hear those words. And we feel that that is a misused name. First of all, when my fellows come to me to say that somebody has atypical chest pain, they aren't trying to say that they're presenting differently. What they're saying is actually, I don't think it's cardiac. Well, for that very reason, we said the terms you should use are cardiac, possibly cardiac, or non-cardiac, because those terms are more specific to the potential underlying cause. But the way that we use this, atypical, it doesn't really help us take care of the patient in front of us. It can be misinterpreted as benign, and that is a class 1 recommendation to not describe chest pain as atypical. It specifically gets used towards women. And as I already said to you, 90% of women and 90% of men actually report chest pain or chest pressure with the typical symptoms. Whether we talk about young women in the Virgo study, they demonstrated that, whether we talk about the high stakes group that also reported actually more women had what you'd call typical symptoms, or whether you look at the AirMaze trial where they used artificial intelligence or cardiolinguistics to listen into the conversation to hear if a patient said chest pain. And this computer with no bias in it said that 90% of women and 90% of men reported chest pain or chest pressure. So we really need to get a way of describing things as atypical, because I think it always gets pointed towards women. Women are 52% of the population. Their symptoms are probably more typical, to be honest with you, than anyone else if you take the population majority. So lastly, our last letter stands for structured risk assessment should be used. And that's what the guidelines actually provide, is a structured risk assessment, a proper approach to acute chest pain and an approach to stable chest pain, so that you can really use evidence-based diagnostic protocols. Now, in our chest pain guidelines, we have some new concepts. So we now define coronary artery disease differently than before, because we actually define it to include both obstructive and non-obstructive coronary disease, which is the entire spectrum of coronary artery disease. And in the past, we really talked about coronary disease like you had to have an obstructive lesion. And I think it's an important thing that needed to be addressed in these guidelines. We also talk about prevention. There's a big focus on guideline-directed medical therapy from actually work that Dr. Maron has led a lot of these studies. And we felt it was very important to always be asking these questions. I don't have enough time to dive into it, but you'll see it in every part of our guideline. If you know somebody has coronary disease, before you do additional imaging, the first question is to ask, are they on guideline-directed medical therapy? Maybe that's all you need to do. We also, from a primary prevention standpoint, talk about the role of when you might want an exercise treadmill test or coronary artery calcium, when you already know that somebody doesn't have disease, to use that information to prevent cardiovascular disease altogether. So again, one other important thing in our guidelines is our focus on the non-obstructive coronary disease. And we actually give a pathway for patients when you don't identify a tight lesion, that we have now an ANOCA pathway built into our guidelines. And I think that that is something novel and new, and that was missing from our literature. So we felt strongly that we needed to really help our community, our cardiology community, to look at non-obstructive coronary disease, a disease state that really affects women more than men, but also does affect men. And we now do have some randomized trials telling us that when we do functional testing in the cath lab and we make a diagnosis, people do better. So we should be doing that more in our cath lab. And it is encouraging that since these guidelines have come out, we have seen more cath labs actually doing this, making measurements to try to make a diagnosis in these patients. Now, not everyone does it in their cath lab, but we can harness the power of our imaging testing, which can also help us make a diagnosis. So again, using PET or cardiac MR is preferred. In Europe, they tend to use a lot more echo. We have limited data about the use of echo, but it's certainly a possibility to use it as well. But I think that these patients deserve a diagnosis so that we can target treatment. So our guidelines provide us, one thing, there was no chest pain guidelines before it, so it's the first of a kind, but we were able to update our guidelines with randomized trials that had occurred in this last decade. We also introduced this new terminology to get rid of the word atypical. We've redefined coronary artery disease to mean more than just obstructive lesions. And we've also given a pathway for our emergency room and for our clinicians to eliminate unnecessary testing when the patient is deemed as low risk, or also when there's just simply a need for guideline-directed medical therapy. And we have really emphasized that point, that medical therapy for patients with known coronary artery disease may be what we need to do before we do additional interventions or studies. So for the future, we need to know how we can improve the time between the onset of symptoms for patients experiencing an acute coronary syndrome. And there's ongoing trials looking at that with patients who already have established coronary disease. And we'll see if home initiation of medications might help us here. I think for ANOCA and MANOCA ischemia with no obstructive coronary arteries, there's obviously still a lot of gaps of things we don't know, including the ideal management for them. And so there's ongoing studies that hopefully will help us with that in the future. I think the symptom classification is important, and it's not just about sex. It's also about people of diverse backgrounds that might describe things differently, or that our healthcare community hears things differently. And again, using machine learning, harnessing the power of artificial intelligence, I think is so important for us to really step into the next era of how we can improve our care of all our patients. And of course, we need to know how our decision tools work adequately. Again, we've given pathways, but it would be great for us to know more about how they work. We also need to know more about high sensitivity troponins in the US population in particular, because we've only really had experience with them fully in the last 3+ years since we've rolled these out in our hospitals. So that's a lot of talking for me about these chest pain guidelines. I'd just like to point out that this was a team sport, and the team included patients, emergency room physicians, cardiologists, imagers. I think that it's important to recognize the people from very diverse backgrounds helping us create these guidelines with all kinds of expertise, cardiac surgeons as well. I forgot to include them. They were part of this as well. And we have many endorsing societies, the American Heart Association, the American College of Cardiology, as well as our imaging societies that helped us bring these all together. There are resources. You can go to our apps that are available for free. All these slides are available at the ACC Chest Pain Hub as well as at heart.org. And we also have patient resources as well, like from CardioSmart, this infographic, and of course the guidelines that are published in numerous places, including Circulation and JACC. So I'd like to thank you again for inviting me here today to talk about the chest pain guidelines. And I'm not sure if there's time for me to answer questions, but I'm happy to take questions if you'd like.
Thank you so much, Martha. That was really outstanding, tour de force. And I would ask people to submit questions online. And there is one from Mathew Ito, who says, great presentation, Martha. The shared decision-making tool is novel. How does it perform between different ethnic, racial, gender, and age groups?
Yeah, great question, because I think, shared decision-making tools, we really do need to use them in the population affected by the diseases. And one of the limitations with all shared decision-making tools that are out there is you should ask those exact questions. Do they work in the patients I'm taking care of? Have we tested them? So the work that Dr. Hess did was at the Mayo Clinic, and I guess you'd have to say that population is where it worked, which is a predominantly Caucasian population. And I think that we still need it to be tested in other populations to really say, does it work effectively? Does it connect with patients of diverse backgrounds? As I showed it to you, it doesn't really show people of a particular race. They're kind of, images that they use, and they tried to be unbiased in what they used. I think from gender and from age, they had a diverse population, both men and women it was used in, as well as diverse ages. But I think that race, they could probably have done better. But the novelty of their tool that I just want to emphasize is that they actually tested a tool that could be used. The problem, I think, is that tool doesn't get implemented in our emergency rooms quite in the way that I would want it to be used, because we really should be using it in our low risk population and be asking these questions. Do we, are we over testing in the low risk population? Is it just easier to do a test? Or would it be easier to apply this 3-minute shared decision-making tool? And that's what we need to overcome, because I think the clinical inertia still exists, even having this excellent tool out there. But I agree with you, Mathew, that it probably needs more testing in more diverse populations.
I was going to ask a similar question. You spend so much time developing the guidelines. It's a huge amount of work, takes a lot of time, a lot of resources. What is your sense about their adoption or translation into practice? Do you have any way of measuring, of knowing?
No, right now, no. I think maybe insurers might tell us how things are going and how things are changing. And we'll, they've only been out a year. Actually, it was a year, I think, this month. So I think we need to look at over time what is being used. But I think the idea of introducing anatomic testing to functional testing, basically us having an arsenal of different ways of making diagnoses, I think that's an important thing for us to know. How is the uptake and the coverage, obviously, of the tests that we're recommending. But also, I think what I would like to see, and I hope that we can get some data regarding this, is in the low risk group. Are we still testing the low risk group when we're saying you don't have to do it? I think the emergency room feedback, if you will, to us was the most valuable thing that they saw in the guidelines. They want to know when they can say, I don't need to test this person. And of course, from an emergency department, you don't want to miss anyone. And we have to trust the tools that we have and our risk calculators or clinical decision pathways. And we also need to be able to effectively communicate to our patients when they are low risk that maybe they don't need additional testing. So I would like to see utilization data in our emergency departments moving forward.
Great point. I just appointed myself as the moderator, since I was the last minute person to introduce you. But let me ask people who I can see as part of the leadership group, if anyone has some questions for Dr. Gulati, and until I see. Oh, well, let's see. Oh, there was Maddie said thank you. Yes, Bill, did you have?
First of all, I wanted to thank Martha for an extraordinary presentation of a lot of work. We certainly appreciate all of that effort. Right now, we're using some algorithms and shortened ones. At what point in the future do you think we will rely on artificial intelligence to answer all these questions for us and bring in all the parameters? In other words, comparing age and other areas, troponin levels and C-reactive, and coming out with the definitive recommendation. We can get in a Tesla at this time and drive across the state without even thinking. Will there be a time when artificial intelligence becomes better than the average emergency room evaluation?
Well, it's still an art as much of a science, but I do think we should embrace the utilization of technology. And I think putting in artificial intelligence, once we have something that works well to not miss patients, I think that that's what we're looking for, a tool that will help us find the patients that need additional testing. But I think, are we there right now? No, but I think that we should be embracing technology to try to help us, because it will make us better. What every emergency room physician's nightmare is missing someone, right? That's what they don't want to do. So we need to try to find tools that help us know who can go home, but also who needs additional testing. And I think that that's what makes this era right now quite exciting, is embracing technology that can combine all pieces of information, but it will never erase the healthcare community. Obviously, the healthcare community has to know what to ask. The healthcare community has to be there, just making the decision even about getting the tests that they want, whether that be an EKG, whether that be blood work, or whether it's not cardiac altogether. And of course, I gave a very cardiac centric presentation, but that's the art of the history taking and the emergency department, the front line of medicine that we'll need there. But I do think that artificial intelligence does have a place when we can figure out if it's as good as us in terms of taking all the information it's given to identify those the greatest risk. And that includes even our electronic health record may be able to, once labs are there, once the EKG is there, saying this is somebody who already, based on the history taking, because we all type it in, saying that this is somebody who's in a higher risk group. And I think we shouldn't be scared of it. I think we should actually try to find the best way to take care of our patients.
Dr. Joe Sky has a question.
Yeah, thanks for the excellent presentation. And as some of you know, I practice in the military where we don't have a financial conflict of interest between who does what, and we've always had a more collaborative approach to chest pain with our ER colleagues. Can you part of this and what that type of collaboration is taking place in the real world now that this has been out for a few months?
Sorry, Joseph, you went in and out, at least for me. I'm not sure if everyone got it, but I think what you were saying.
Oh, I'm sorry.
Correct me if I got it wrong, but how do we get collaboration? Is that kind of the question?
Yeah, and so I practice in the military where we've always had more collaboration because we don't have the financial disparate interest between the different departments. And I'm curious because you did a great job on the guidelines from my perspective of making chest pain a more collaborative effort. And obviously the emergency room physicians were part of the guidelines. Have you seen that is having an effect in the real world since the guidelines came out to have more of a common language and a collaboration between the emergency room and cardiologists?
Yeah, I think it has actually. I mean, again, time will tell, but I think within this first year, we've had such good feedback from our emergency department colleagues. You know, what they want, it's not obviously, they don't want to call cardiology if they don't need to call cardiology. You know, I think that's the point that you realize. They just want to do right by the patient that is in front of them. And I think that's what these guidelines really did provide is, you know, from the initiation of someone presenting with chest pain, we've always had guidelines once you made a diagnosis. These are the first symptom-based guidelines that we've ever had. And because even syncope, we had syncope guidelines, but that's kind of a diagnosis versus chest pain is so non-specific until you really dive into it. So I think that it has allowed us to communicate more effectively with our emergency department colleagues. And when they're calling us, we know why they're calling us, and being able to manage a patient and tell them, okay, yes, when you're saying low risk, we're all on the same page. We understand what sort of scoring system you use in the emergency room. And then I think that it makes us more collegial to our friends in the emergency department because we know when they're calling, we're useful. I think the other thing is, of course, you know, like you said, in some systems, it's a competition about even imaging, like who does the imaging, where it gets done. For the emergency room, you know, to them, it's what can I get done quickest to get my patient into the right place? If they need to be admitted, or do they need to, you know, is it all right for them to go home, or should they be an observational unit? And I think for the emergency department, we don't want to make that their problem. We just want them to have a pathway to get the best testing done in the most time-effective way, because that's what matters in the emergency department.
We have a comment from Dr. James Schultz and a question from Nancy England in the audience. So from Dr. Schultz, as a hospitalist, we spend a huge amount of time and resources doing defensive medicine, admitting patients with likely non-cardiac chest pain, and do a lot of nuclear stress testing. Any guidelines that can better stratify these patients in the ER would be helpful, exclamation point.
Yeah, and I agree with you, Dr. Schultz. I mean, that is what we hope we provided. I know that sometimes these conversations aren't taking place in the emergency department and it's easier to just admit them. Our hope is we can change this so that the ED starts applying that shared decision-making tool for those low-risk patients, those patients with most likely non-cardiac chest pain. We understand the patient's fear, but if we spend a little bit of time, 3 minutes, that's what it takes to use that tool. If we spent the time with them, I think that would be much more cost-effective than admitting them to your hospitalist service. To your point, once they're there, you feel like you have to give them something because at that point they're convinced they're admitted. Something must be wrong with me. And I do understand the situation we put the hospitalists in. So again, we're hoping that again, our emergency room is the front line. And if we can work more effectively with them and they can understand these guidelines, we've given them a pathway and permission to send certain patients home with follow-up as an outpatient. It doesn't mean you just send them home and say, oh, well, we're done with you. Remember that we're saying deferred testing. So they might come to a cardiologist later and get additional testing, but it doesn't need to be done in the hospital.
A quick couple of comments from me before we go to Nancy England. I ran a chest pain center at Vanderbilt University for many years. And the emergency medicine doctors, because of the horror of being sued, really wanted me to make decisions. And I would push on a patient's rib, it reproduces the pain, and I would discharge them. And it was okay with the emergency room doctors as long as it was on me. And I was very confident of my diagnosis. The other thing that I introduced was doing CT angiography much quicker than waiting for a nuclear stress test like you're doing, Dr. Schultz, at your hospital. And I would say more definitive. I don't know how to have Nancy England, Hattie, or Jenny help me. Nancy England has a question or comment.
I can allow her to talk.
Okay, well, please allow her to talk.
I think Dr. Budoff.
Nancy, could you please unmute yourself? Nancy, I cannot see your question and you are muted. You're able to speak for yourself. And meanwhile,
okay, let's go to Dr. Budoff.
Maybe we should go to Matt.
All right. So, Martha, wonderful talk as always. Thank you so much. I just wanted to, kind of follow up on David's point, not necessarily even CT angiography. We did our first study of coronary calcium back in 1999 and published it in JACC in 2001, showing outcomes are pretty safe. And I think I was pleasantly surprised that you guys adopted that for these very low risk patients. And I think sometimes even doing it just to reassure the patient that their coronaries are clean, they're low risk, they have calcium score is not as definitive as a CT angio, but it's an easy way it's an easy test to do in the ED because CT scanners are everywhere. It doesn't require contrast or beta blockers. So I just your thoughts about that, because you were probably the first to raise that in 20 years as a treatment option.
Yeah, no, and we put it in there, we debated a little bit about that, do we put it even as a higher recommendation? We know, again, some places have CT, some places don't, but everybody seems to have a CT in their ER that they can access at almost any hour. So I agree with both you and David. I think that their, CCTA answers the question. And for the nervous patient, the patient that needs to know, or, maybe they've come back, they've had this pain for a while. Sometimes you just feel like you have to give them an answer, and you can give them using CTA right away, and disease or no disease, but certainly a possibility to use coronary artery calcium. I think harder in the emergency room from what we understand in terms of them being able to order it and get it. But that's where deferred testing comes in. And maybe that's what you send them out with. Even the emergency department could send them out with a coronary artery calcium order, and then a follow-up with a cardiologist to discuss those results. And that's what I meant by, even the idea that prevention is still in there, because you might get the coronary artery calcium. It's not that you need to do anything necessarily about it from an acute setting, But obviously as a preventive cardiologist, and you can't have a preventive cardiologist lead these guidelines and not expect us to sneak prevention in there. And really prevention, when you have a patient there, they've experienced chest pain, and yet it's not an obstructive lesion, but you say that we've got a plan moving forward. I think that also is a very valuable to the individual that is experiencing that and wanting to know their own individual risk. Because what we can't put into the guidelines, is the person's individual experience, their fear of what's going on, and giving them answers. That's why I call it deferred testing too, that yes, you might do it in the emergency room, but you might do it later. But the patient doesn't, they need to know what's going on. They need a diagnosis of why did they have chest pain.
And I'll just add that when a CT angiogram is done and there's no obstructive disease, but there is non-obstructive disease, it's a great opportunity to initiate appropriate preventive interventions.
Yes.
And that's probably why we saw a reduction in mortality in the Scott Hart trial.
Exactly.
We've hit the top of the hour. And I just want to thank you, Martha, for a wonderful presentation. It's great work. Wonderful way that you get through a lot of information, save time for good discussion. Thank you.
Thanks for having me here today.
I
And
just would like
Maddie's
to
gonna
say
speak.
one more thing, and that is we have had a presentation by Gunderson Healthcare's Executive Vice President for Medicine about how he uses incidental coronary calcium findings and direct coronary calcium findings in the emergency room in the situation to say, gee, if this person has a significant coronary calcium score, I'm going to triage this patient quite differently. So I wonder, we were talking about that in our last live meeting in LA with a lot of our leaders, and I wonder if you've considered that.
I think that was a question to you, Martha, about when you detect, what's the utility of the discovery of incidental coronary calcium on a non-gated chest CT that was done for other reasons?
Well, I mean, we didn't address that specifically in the guidelines, but of course, in a clinical practice, when you have that data, you use that data, right? So knowing that somebody has a coronary calcium from any type of imaging that they had, I think most of us, before we even see a patient, we look to what other tests they might have in their medical record. And when we see something that says calcium, I don't necessarily say you need to go out and get a coronary artery calcium, because my recommendation is probably going to stay the same. And that is the issue, because coronary artery calcium does cost money, and it's not a possibility that, very few insurances pay for it. So if they have the data already there, we should use it. But again, this also gives us a reason to want to push to get these studies covered by insurance and by our system, because they are incredibly valuable. We've come like a full wave. Like back in the day, people used to say coronary artery calcium was a marketing tool, and now we have so much evidence that it helps us stratify patients. It's surprising that there isn't coverage for it, and that is probably the biggest limitation of getting a coronary artery calcium, is for certain populations, even when it's $100 or $200, that's $200 they don't have. But yes, you should use the information we have.
Thanks, Martha. Thanks for your leadership of the guidelines, your leadership for women in cardiology. Keep up the good work, and I'll see you soon at a ASPC board meeting.
So let's first go to David Maron's bio, please.
Oh,
So
we don't really need my
we
bio.
all know
Thank you.
who David is at this point, but I want to commend him for the interview that he conducted of Denmark's Axel Diedrichson. And with that, I think, Jenny, why don't we go directly to the interview?
Yeah, so this is an interview I conducted recently with the principal investigator of the DANCAVAS trial. Here we go. Today to have the opportunity to speak with Dr. Axel Diedrichson from the Elite Research Center of Individualized Medicine in Arterial Disease, Odense University Hospital in Denmark. Dr. Diedrichson is the senior author of the massive study just published in the New England Journal of Medicine, the Danish cardiovascular screening trial, or DANCAVAS. Welcome, Dr. Diedrichson.
Thank you so much for inviting me.
And thank you for taking time to speak with us today from Denmark. And congratulations on the publication of the 5-year results of DANCAVAS. To start things off, could you please describe the design of the trial and then report your principal findings?
Well, the DANCAVAS trial is a huge trial. We identified all men in certain communities in Denmark. There was 64,000 altogether. And we randomized those either to usual care or to a screening examination. So 1/3 were invited for a screening examination and 2/3 were invited for just left for usual care. And they were not told about the study. So we invited approximately 16,000 men at the age from 65 to 74 years to the screening examination. It is comprehensive screening. First of all, it was a CT scan, among others. And then if we had found significant findings like Captain score above the median for age and gender, we would prescribe preventive medication. The screening started back in 2014, and the last one was examined in the start of 2018. And now we have got the 5-year results presented at the ESC recently. And we found that the all-cause mortality was not decreased significantly. It was close, but not close enough. The hazard ratio was 0.95 and the p-value was 0.06. Sorry about that.
Could you describe what other tests aside from CT were performed as part of the battery of tests that you used for screening?
Yeah. So the participants, they first, after they signed informed consent, we had blood samples to evaluate blood sugar and cholesterol. We also measured blood pressure and arm and ankle brachial index to evaluate if there were peripheral disease. And during a CT scan, we were evaluating the heart rhythm to find unknown atrial fibrillation. And finally, the CT scan, as I just told, we measured coronary artery calcifications, but we also measured aortic size of the entire aorta. So 7 things, we screened for 7 things.
And how did you decide to screen with a number of tests instead of just picking one?
It's a hard question for me to answer. But first of all, I have to tell that my co-investigator, Jes Lindholt, he is a vascular surgeon. I'm a cardiologist. And he knows that screening of aneurysm is a benefit for the general population, from screening of men at least. He had this very huge screening trial called VIVA in Denmark also, where he invited more than 40,000, I think, were screened at that time. And the explanations were ultrasounds for abdominal aneurysms, and they also measured ankle brachial index and hypertension. So when we met, Jes and I, back in 2014, he knew that there were significant value of the aneurysm screening and also of the peripheral artery disease screening. So that was what he came with, while I was a cardiologist and I came with a CT scan of the coronaries. The other measurements, traditional risk factors like hypertension, diabetes, hyperkalemia, we decided to go with these also. I think if we didn't, would have been much of a debate on that afterwards if we did not look for the traditional risk factors. And finally, atrial fibrillation is so easy. When you do a CT scan, cardiac CT scan, we always look at the heart rhythm. So we taught the clinicians how to identify atrial fibrillation, and they did. So that was for free.
Right, that makes sense. Now, in your findings, you noticed that there was a benefit in the younger part of the population that you screened. Could you tell us about those results?
Yeah, so we planned to do a sub-analysis. We divided the men in two age groups, the ones from 60 to 69 years, and the ones from 70 to 74 years old. So we had predefined this subgroup analysis, and we found a striking difference. The age group above 70, there was no benefit on all-cause mortality, no benefit at all. But it was a huge difference, I believe, in the younger group. So hazard ratio in the younger group was 0.95, 11% decreased mortality. It's really impressive. We're talking here about all-cause mortality. And the p-value was 0.004, I think.
Could you repeat sorry to interrupt, but could you repeat the hazard ratio for the younger subset? And I believe the younger subset was ages 65 to 69. Is that correct?
Yeah, so the hazard ratio for the younger subgroup, ones from 65 to 69, the hazard ratio was 0.89. So the all-cause mortality risk was decreased by 11%.
Now, why is it that women were excluded and you only studied men?
That is a tough question. I've got a lot of criticism because of that. But well, in the beginning, back in 2014, we did examine women and men. We did invite more than 1,000 women and more than 1,000 men. And we evaluated if there were difference in the findings. And women, they do also have coronary artery calcification, certainly do have, but not not at all as extensive as the men. So significant captain scores, like captain scores above 400, were common in this age group of men, but uncommon among the women. And also aneurysms. This is not a women's disease. It's very uncommon to find aneurysms among female. So we thought, if this screening does not work among men, we have all these significant findings, it won't work among women. So we were looking at our funding, and we thought we would get more value for the money if we just look at men. And so we did.
That was a tough decision, as investigators often have to make difficult decisions because of pragmatic concerns.
It was a tough decision, yes.
Now, I saw that you had included some people with a history of heart attack or stroke. Did they sort of sneak in, or was that part of the design? Because it seems unusual. Why would you screen patients with established atherosclerotic disease?
Also a good question. The first answer is that if we look at men with prior stroke and prior MI, the risk of having an unknown aneurysm is higher. So if we excluded those with prior MI and prior stroke, we might exclude someone who might benefit of the trial.
I see.
That's the first answer. The second answer is that we are talking about a community screening trial. It was not like someone were referred for the screening. We identified all these men in the Danish registries. And we did not ask the Danish registries to exclude those with prior cardiac diseases. So we got all these, we call them CPR numbers in Denmark. We got all, and we provided all. But of course, we knew that this might be a question, and therefore we also set another sub-analysis where we excluded ones with prior cardiac diseases.
And what did that analysis show?
There was not a significant finding there. There was a hint like those with prior cardiac disease had no benefit of the screening, while those without prior cardiac diseases had benefit. But there was not a significant difference between the two groups.
I see. And how is it that you chose all-cause mortality as the primary endpoint? And as part of your response, please mention what the outcome was for the composite endpoint of death, MI, and stroke.
Yeah. Also, the top one is a really ambitious outcome, but actually it's also the best. And when we do screening trials, that's what we really aim for. We aim for decreasing mortality of any cause. It is hard, maybe even impossible to do that when you screen for cancer, because cancer is just one cancer, like breast cancer or colorectal cancer is quite uncommon. So you can't push the all-cause mortality risk when you screen for these cancer diseases. But you might be able to do that for cardiac diseases. This is very common. Not as common as it used to be, but still it is common. So we thought we'll try to go for that. There will be no arguing afterwards. If we were able to prove to decrease all-cause mortality, we had a very, very strong argument. But that was a risk. So we had secondary outcomes, of course, stroke and MI, aortic rupture, and so on. We found a significant decrease in stroke and the tendency, very strong tendency to decrease myocardial infarction. There was no difference in the vascular outcomes, the other vascular outcomes. Post-hoc, and it was a post-hoc analysis. We thought we'd like to present what cardiologists like to look at. We like to look at composite outcomes, combining mortality, stroke, and MI, also heart failure actually. But the first three, we made this composite outcome, and that was highly significant. The hazard ratio was 0.93.
Thank you. So you powered the trial for mortality at 10 years, but you reported these results at 5 years, which is really an interim report when you were really not expecting, as I understand it from your power calculations, to see a significant reduction at 5 years. So explain why you reported at 5 years, and wasn't that taking a risk that people will think that screening is not effective in the event that you found no significant reduction in mortality?
Yeah, we actually plan to do a free analysis after 3, 5, and 10 years. But the 10 years is the one we go for with a total mortality, all-cause mortality. The free publication analysis were never done because of COVID. But we did the 5 years as we set up in the very beginning. We thought we were able to find a decrease cardiac disease due to the screening examination. It was not very clear in the protocol, however. And of course, we look so much forward to see the 10-year results. I'm not quite sure what will happen. I mean, at the very end, we'll all die. So all-cause mortality, it will end the very same with the same thing. I'm curious to see, and looking forward to see how it does look like after 10 years. Is it correct what we anticipated to decrease the all-cause mortality by 5%?
We certainly look forward to seeing the 10-year results.
Mm-hmm.
Now, 63% of the men who were randomized to the screening group actually were screened. Is this the rate that you expected?
No, it was a little disappointing. We had in our prior in our prior screening trials, we had a higher respondent rate. We expected around we expected more than 70%, but we hoped for up to 80%. So we were disappointed and surprised about this low participation rate.
And so I think that may have affected your results with an intention to treat analysis. Can you explain why you analyzed according to intention to treat or intention to screen, as opposed to analyzing by those that were actually screened versus control?
Yes, I will try to. First of all, I also think it might have decreased the hazard ratio that we were unable to get we weren't able to get a higher participation rate, and our participation rate. What I'm trying to tell is that. Sorry, can please answer my question? Answer your question again, please.
Well, so can you explain why you analyze by intention to treat, which is, from my perspective, is the proper way to analyze the data, but you had a less than expected rate of participation from the men who were invited to be screened. Only 63%. You were hoping for closer to 80%. And this probably affected your results. If you could explain why you analyzed the data according to the invitation rather than the actual screening.
Yeah, I will try to. So it is correct that the data might have decreased the hazard ratio, that we didn't manage to get more participants than 63%. I think so also. Well, when we compare things, they have to be comparable. So if we compare the participants with the entire country group, we are doing something wrong, because in the entire country group, there will be people there who like to participate in screening, but there will also be a lot of people, more than 30%, who wouldn't like to participate in the screening trial. So we compare attendance with the control group, and this control group, we know for sure there is a lot of people with a high morbidity who would not participate, and therefore would have a higher mortality. So these things are not, they are uncomparable. We can't compare them. That being said, of course, we have done the analysis, and not surprisingly, there's a huge difference in hazard ratio. It is 0.5. I don't know if that is remarkable. I don't know what we can use it for, but also a huge difference when you compare two groups.
Yes, that is a remarkable result. And well, if we're, let's say, public health agencies or different countries were going to apply the results of your trial, if you're doing a population screening and more than a third of the population doesn't participate, that's real. And that's I think, the justification for doing an intention to screen analysis as you have done. But very important to know that among those actually screened, there was a 50% relative reduction in deaths. That's remarkable.
And it's also a reason, important reason to remember, important to remember that when we analyze, when we look at our results, I mean, we were almost able to decrease all-cause mortality in the entire group, and that despite 1/3 did not participate.
Yes.
I mean, we can't, those not participating, we can't help them. So the participants, they do really have to do good if they're going to improve, decrease mortality in the entire group.
Now, looking with a little more detail at the intervention after screening, did you actually prescribe aspirin and atorvastatin, or did you make that recommendation? And if it was the recommendation, did you recommend it just to the patient, or did you involve the primary care clinician?
We did all three things. We informed the participants about the results, and we prescribed the medication, and we also informed the prime physicians about the results and urged them to continue their prescriptions. We prescribed medication for a while, but not for 5 years of treatment, of course. So the prime physicians had to take over.
I see. Okay. Now, it's been shown in a few studies that if you actually show a patient a picture, an actual image of their atherosclerosis, that it improves the initiation and adherence to preventive interventions, and ultimately lowers cardiovascular risk. In DANCAVAS, was this done? Were people shown, those screened, and I'm thinking really about coronary calcium scans, were people shown their images, or were they just told about them?
They were just told. In our subsequent screening trial, we call it DANCAVAS 2, we examined men, sorry about that, aged from 60 to 64. And within that trial, we have got a number of randomized trials also. And one of these is exactly what you asked for now, showing images of the patient's calcified coronaries versus not showing images about the calcified coronaries. I've got no results of that yet, but that was also from DANCAVAS 2. DANCAVAS itself, we did not show pictures.
Okay. Now, what do you attribute the reduction in mortality that was seen, and the significant reduction in the 65 to 69-year-old group? Why do you think mortality was reduced?
I think that's because of the medication we used. In the younger age group, aspirin were not that common used. But after the screening, we recommended that half of those with a median Kaplan score above expected for age and gender, we recommended half to take aspirin. And I think it was just one out of 4 did prior to screening. So after screening, maybe not every second, but many more did take aspirin. Likewise with statin, there were more, however, on statin prior the screening explanation, but after screening explanation, many more did have aspirin. So I think that I did take also statin. So I think that aspirin and statin, maybe most aspirin, did explain the results.
And do you have any information about lifestyle interventions? As I know that was part of the counseling that was done for people in the screening group.
It was. We recommended healthy living. We talked about cessation of smoking and diets and activity, like we always do when we see patients. We unfortunately we do not know if these initiatives were successful. We don't know if they quit smoking and so on.
Now, in retrospect, well, let me ask, why do you think the benefit was greater in the younger age group? And do you think that if you had included even younger men in this case, that the benefit might have been even greater? Or do you think there's just a narrow sweet spot for the benefit of screening?
So the first question, why did it work in the younger age group compared to the older? I think there's a couple of reasons for that. First of all, participation rate. It was higher in the younger age group. It was not a huge difference, but there was a difference. If you don't participate in the screening, we can't help you. So that was one reason. Also, the younger participants, sorry, the other way around, the elderly from 70 to 74 years, they had higher comorbidity. They were more used to take aspirin and statin and so on compared to the younger. So if we invite someone to a screening examination and we prescribe statin and aspirin, it won't make any difference if they already are on statin and aspirin. Opposed to that, the younger age group, there were fewer in treatments and there were higher participation rates. So we were able to find those with significant calcifications, and we were able to prescribe them with this preventive medication.
I see. So what do you think about what would happen if even younger men were invited?
Yeah, okay. I'm very curious to know that also. As I told you, we have a finished inclusion, including younger men from 60 to 64 years. I think that stopped for 3 years ago or something like that. So we have, in a few years' time, we'll know if the younger men will benefit of screening examination compared to the DANCAVAS trial participants. Looking at our results, I think that young men will benefit. But if we examine 2 young men, also women, if we examine 2 young people, we'll need to screen a lot of patients, a lot of participants to find anyone with significant findings. And the risk will be low also. So your younger participants, you screen, you need to include, and a longer time have to wait until you can see any benefit.
Well, by the same token, do you think that if you had included older women, that you would have had a high enough event rate to show benefit?
Hard to answer that question. First of all, well, I don't know, so it's just speculations, but we found that participation rate was decreasing with age among the men at least. And if that also goes with women, one might fear that the participation rate among this elderly women, if we examine women from the age from 70 to 79, or even from 75 to 84, these elderly women would not participate in this examination. So it really depends on the participation rate. But if they would participate, they might benefit.
Okay, fair enough. Now, you also did a cost effectiveness analysis. Mm-hmm. And could you briefly summarize what you found?
Yeah, it was cheap.
That is a brief explanation.
Okay, I'll try a longer version then. We evaluated all costs in the screening group and in the control group. So the cost of the screening, the cost of medication from the day of randomization, the cost of visits by the general physicians, and also cost to the hospital. So all costs regarding cardiac diseases were selected. And we found that the difference between the screening group and the control group was 207 euro. We also estimated the quality of adjusted life year gained, and we found that the price per quality adjusted life gain was 9,000 euros. So if you pay 9,000 euro, you get one quality adjusted life year. That was an entire group. We looked also in the younger group, men from 75 to 69, and it was much more cheaper there. The cost was only 4,000 euro. And these numbers may not make a lot of sense, but if we compare to screening exhibitions for cancer, it is very cheap. Breast cancer is about 20,000 euros. Colorectal cancer is up to 40,000 euros. Of course, it's difficult to compare this different screening examinations trials, but it is cheap.
Yes, highly cost effective.
And if I may say one more thing, this is a screening examination done in Denmark. And we can see that participants with these high calcium scores, we told a lot of men, you've got high calcium scores. They were not secondly referred to they're not referred for like invasive angiographies, and the reassociation rate was not increased. So downstream testing was not a problem in DANCAVAS. And I think that it is a very important issue to keep in mind when you discuss how to use the DANCAVAS trial, how to use the results, to remember it is made in a country with this setup where we don't do a lot of angiographies and we don't do a lot of revascularization just because of a high calcium score.
Very important comments. Now, you learned a lot from conducting this trial and analyzing the results, and knowing what you now know. What would you have done differently in the design of the trial?
Probably a lot of things. I learned a lot during these 8 years, and also I learned a lot the last month and even weeks. First of all, I think I would go with the men still. Maybe I would investigate more younger men. The outcome, all-cause mortality, it should not be the first. It should be a second. I see the first outcome should be a composite outcome, as we always do in cardiology. So if that is positive, then we go further to see the secondary outcomes. I learned that. And the screening explanations, when you see the changes to medication, I can now see that the screening of hypertension and diabetes and hyperkalemia is of no value in our study, at least. Likewise with atrial fibrillation, we did not use more anticoagulation in invited groups, so it seems also to be a waste of time. And lastly, with peripheral artery disease and aneurysm, I had to be good friends with my colleague, yes, and he'll be very, very upset, oh sorry, if I tell that these explanations might also be used as. Of course, I don't mean that, but I think I should go just one explanation, the coronary artery calcification score.
The coronary artery calcification score.
Yeah.
Right. Well,
I don't know that in English. It is with a lot of, I'm not very sure on that, how can I tell that in English, but I believe that the coronary calcium score was the most important one.
Okay, well, I think that was the end of the interview, and some chit chat about trial design was lopped off. Dr. Budoff, can I call on you and ask you, are you there, Matt?
I'm here.
What questions would you have asked that I didn't ask?
No, I thought you did a great job, David. Honestly, I thought you covered quite a bit of territory there, including, what would you do differently now that you know the results? But I think it's just the one question I'd like to know is where can we see that 50% event reduction data, other than saving a clip of this video? Because I don't remember seeing a hazard ratio of 0.5 anywhere published in the article. Maybe I missed it.
Oh, no, you didn't miss it. It's not published. And if you would, Matt, tell us your thoughts about intention to treat versus as treated analysis.
Yeah, I think with scanning especially, I'm not aware. We've done a lot of epidemiological studies, MESA, and they've done them in Germany and all around the world. And we only include people who actually participate in the trial. So we didn't talk about the 12,000 MESA participants that were invited to join and didn't choose to, or whatever that number is, or the Heinz-Nixdorf recall study. They included the people who got a scan, and the scan was a requirement to be in the trial. And I don't know why this would be any different. I don't understand. I understand if you're trying to say, well, if we made this a population-based assessment, how effective would it be overall? But I think it's a little different than a drug where you might have toxicity that they can't take the therapy. And even in a drug trial, they're not randomized until they sign a consent and are given the first pill, or at least sign a consent saying that they're participating. So keep in mind, in the Jupiter study, we screened even 78,000 patients to get 17,000. You can't read about the 78,000 and how poorly they did because they weren't on Crestor. You can only read about the 17,000 who are randomized. So I think even intention to treat is based on signing the consent form, not on getting a letter in the mail. Maybe they were dead. Who knows why they didn't show up. So I thought it was quite odd and very atypical from any study ever done in the history of science. I'm not aware of anything where a letter counts you as being, an invitation counts you as being included.
Okay, well, there's one member's strong opinion. Are there any other opinions among the panelists?
Well, I guess I should defend attention to treat because that it is a standard in clinical trial research that goes back probably 50 years or so. And the argument is that in order to establish, so Matt's really talking about representativeness and generalizability of findings, but in order to establish causation, intention to treat guarantees equivalence between the comparator groups. And David, it probably goes back, I'm pretty sure it's the coronary drug trial that goes back into the 60s, where people, I can't remember the agent, it was pre-cholestyramine.
Well,
was
it was niacin and clofibrate.
Clofibrate,
and thyroid hormone and estrogen. All four were in the coronary drug project.
And so this was, I think, just the clofibrate portion, but as I recall, people were randomly assigned to drug or placebo, and that they looked at those who adhered to the treatment, and there was a big effect, and they submitted to the New England Journal, and the reviewers said, well, you can't really do that because that you didn't do the same compliance analysis for the placebo group. And so when they did that in the placebo group, they, lo and behold, found that those who adhered or accepted the placebo also showed the same effect at about the same level as those on
Drug.
that adheres versus non-adherers. And this has been a very consistent finding. Alvin Feinstein had a famous paper on this. So people who accept treatment, whether or not it's active drug or placebo, or screening or no screening, tend to achieve better outcomes than those who don't. And there's just lots and lots of examples, and there have been several meta-analyses on this problem. So those who accept screening tend to have better outcomes than those who don't, and that could be independent of the screening.
But Bob, we're not talking about intention to screen. We're talking about first participating in a trial. Like the trial, any trial you mentioned, they had to sign a consent before they were considered in group 1 or group 2. They're not considered in a group until they agree to participate in a study.
Yeah, but my understanding was that so this comparison was between those who actually went ahead and got screened and those who, although they had been assigned to screening, didn't get screened.
No, not at all. There was 15,000 people invited to screen, or 30,000 people invited to screen, or 15,000 not invited to screen.
Yeah, if I could, I think that it all comes down to what is the question being asked. And I believe that the question is, what is the effectiveness of screening the population? It's the question wasn't asked, what is the effectiveness of the intervention in people who agree to be screened? And if you're a public agency and you want to screen the population, it's important to know what the participation rate is going to be. So I think that both analyses are valuable. I think it's very valuable to know if you're screened, what is the impact? And there was a 50% reduction in death. That's huge, and it's really important. But Dr. Dietrichson himself made some important observations or speculations that the people who didn't get screened might have been sicker, so they didn't want to for whatever reason because they were sicker. They were definitely older. And so those who got screened were different than those who didn't get screened. And you're comparing them to the control group that's all one big mishmash of all of those people who are older, sicker, and younger and healthier. And so it's not a fair comparison of looking at just those who were screened against all of the control group. So I think that's the argument for the pure science of intention to treat. It's a good, pure way to try to find the answer to a question. But if you're asking, does it help to get screened? The answer, I think, is a very resounding yes. And I think that when we see the 10-year results, the effect size was big enough that I think in 10 years, we'll see the results. And I'm not sure if they helped or hurt themselves by reporting interim results.
I'm sure it hurts if it doesn't hit the endpoint, but I would let you know Rubinska is doing it more traditionally, where patients consent and then get randomized to screening or no screening. And that's just how we do drug trials. And that's kind of the standard. And that's where P.05 came in. And that's where percent relative risk reduction comes in, is based on consented patients participating in a study. So we can, answer any question we want, but we have to recognize that this is an atypical way to do a trial, then trying to compare this to any other study. The MASS trial with abdominal ultrasound, they didn't get counted unless they consented to be in the study. It didn't count just to get a letter in the mail saying, are you interested in participating? So I agree with all your points, but I just think we have to recognize how atypical this study is. It's probably the only study of ever that's done in this way. And that atypicalness, I think, has to be recognized when you look at it, good, bad, or indifferent. This is strange and not typical for whatever reason.
So David, and Matt, let me make sure I understand this, but there has been this finding for years in observational studies. If we go back to women's health, for example, people thought it was a bad idea to do the women's health initiative clinical trial, because they were certain that the answer was already known. But because observational studies had consistently shown that estrogen plus progestin worked great. The difficulty was that women who made the decision to take estrogen exercised more, they were healthier, they watched their diet more and so forth. And all those served as alternative explanations for the outcome. And so do we have something like that here also? That is, the decision to accept the invitation to screen is associated with all these confounders?
Yes.
Dr.
I
Ballmer
think it's
is-
possible, sure, but remember, like the lung cancer screening trial is a good example of something that's been widely accepted, right? US Preventive Task Force has accepted that trial. Every payer that I'm aware of pays for lung cancer screening. They were randomized once they signed a consent. It wasn't, did they hear the ad on TV to participate in a clinical trial? So if we're going to compare it to any other study, I mean, women's health, I mean, you're talking about an observational data. I agree. Observational data could be flawed. I mean, I've spent my life doing it as an epidemiologist, but I recognize the limitations of the healthy, bias, the healthy participant bias. But if you're going to randomize to screening or no screening, and I challenge you, I've looked at all of them, colonoscopy, mammography, lung cancer screening, they were randomized after they consented to be in a study. And that's the randomization to screening or no screening. They were not randomized based on getting a letter from a local center saying, we're doing a trial, call us if you're interested. So I just think this is, I mean, I challenge anybody to find any example of anything even close to this. And I can't. I've looked at all of the screening studies that I'm aware of.
What I think is that this was a pragmatic trial and one that represents what it would be like if you did public health mass screening. I think that might be the justification for doing it in the way that they did. Any other comments from the panel?
David, I think no question about it. The two groups are different. The group that got the letter, responded to the letter, showed up and got scanned is a different population than the group that got a letter, never responded, or some did, but never showed up, et cetera. And we do know that those who are more diligent in showing up for studies and present and follow up tend to, as Robert said, tend to do somewhat better than the general, the rest of their group at that point. So they are different populations, a little bit hard to compare them directly at that point. And I think you all made good points. And as Matt said, the way to do something like this is to first to cross that barrier, find out how many want to participate, show up, sign the consent. That pretty much identifies when you then randomize that those two groups were at least initially very similar in attitude, lifestyle approach to a presentation. But the question I had is, he did, I thought in your interview, say that on initiation of the trial, about a quarter of the people were taking aspirin, he thought, and after they were notified their coronary calcium, he thought it went up to like a half at that point in time. So there was an increase in aspirin in the scan group. And he mentioned sort of in statin as well, but I didn't hear those numbers. Does that mean that roughly in the group that was scanned before the scan, that a quarter were taking a statin, and then after it went up to about 50% or not? I wasn't sure that I understood that. And if so, then I'm thinking that, in a population that's 65 and older, perhaps the 1/4 that is on a statin is sort of low for our preventive populations. Most, if we look our guidelines, most of our guidelines would suggest that by the time you're 65, you achieve what would be almost a moderate risk without a lot of other risk factors, and statin recommendation would be there. So that obviously the treatment here that's going to make a benefit is not the scan necessarily, it's what the scan then delivers in treatment decisions. And in this case, if they're very low in statin, that may reflect the fact that those younger individuals probably did better because it got more of them on a statin. Whereas in the older population over 70, maybe that healthcare system put them on statins anyways, and then we lost the effect of conversion from the scanning at that time.
Bill, I'm not sure what the statin rate was at baseline, but during the trial, the invited group, 20% started on a statin, and in the control group during the follow-up period, 9% in the control group. So more than twice as many started a statin in the screened group. And I'll see if I can find the baseline results of statin use before the end of this hour. Matt, you're co-moderating with me.
Let me just start. No, I think that was a great comment, Bill. And I think I just want to remind people that in the Eisner randomized trial where they randomized them to coronary calcium or not, the benefit was not only in initiation of statin, it was better blood pressure control, it was aspirin, it was diet, it was exercise, weight loss, all were statistically significant. So I think we have the potential to modify more than one behavior. And I realize statin is the low-hanging fruit that we all hang our hat on, but I think some of us might argue that the initiation of an exercise routine may actually provide as much or more benefit, and a combination of good behaviors may even be more potent. And that's how they might have gotten to 50%. 50% seems unreachable until you look at the Scott-Hart trial and say 41%. And then 50% doesn't seem that impossible. Scott-Hart had a 41% benefit in the scan group versus the functional testing group. So, I think it's a combination of factors. Everyone points only to statins, but I think there might be a broader benefit to calcium scoring, at least in my experience as a person who's been doing it and studying it for a while now. Bob, I think you had a question.
Yeah, so my question actually goes in a little bit of a different direction, but this study actually brings up this issue that statisticians have been talking about the last few years. And there was a great paper that's really had an influence on me that was published in Nature a couple of years ago. My UCLA, former UCLA colleague, Sandra Greenland and Blake McShane and some others had this paper that was called Scientists Rise Up Against Statistical Significance. And it was not only them who were very well-known statisticians, but they actually had co-signatures from 800 other well-known statisticians. And they make the argument that, this on-off switch at p less than 0.05 has really sort of outlived its purpose. And so is it really, in this case, p equals 0.06, is that really different than p equals 0.0549? And they lay out that argument in a very clear way. And I think they're getting some traction in the statistics world. And I think it's worthy of some discussion in relation to this study. But there's another side of it, and that is that this is a pretty large trial. So to be right on the borderline of p less than 0.05 also means the effect size is relatively small. And so again, we have this trade-off between statistical significance and proportion of variance accounted for, and that the absolute risk reduction was relatively small, even though the relative risk reduction was pretty large in these subgroups.
I completely agree. I think if you looked at the more standard endpoint for other trials, at least, which is not all-cause mortality, but MI, stroke, and death, which he also looked at, I think the p-value was less than 0.001. So I think you can argue it from both sides, but I agree with you. I think the effect size, whenever effect size is less than, I don't know, maybe 10%, I'm always a little skeptical about how robust that is or how important that's going to be. In general, I mean, we use that for drugs at least. That's kind of a standard FDA cut point, is a 10% effect size. So I think, we might need a 10-year endpoint, We might just need to look at the people who actually got screened to try to figure this out. But I think, unfortunately, we're going to have to wait for a more traditional trial called Rubinska to really get the definitive answer on how effective calcium scoring is. But it does, I think, give great hope that it did reduce MI, stroke, and death. It did reduce mortality, all-cause mortality by 11% in the younger cohort. And if you excluded, I still can't find an analysis when he excluded patients with established CVD, because by definition, they can't be screened. You can't screen a person who's already has known coronary disease. It's just not screening anymore. That's not the proper term. I think we need to see the effect size when you exclude those people who shouldn't have been included in a screening study.
Yeah, I think that they might have included people with established disease because of screening for abdominal aortic aneurysm, atrial fibrillation. Yeah.
I was a reviewer for their second paper, which was on cost effectiveness, and I made them put that in their paper because I still, when reading it over and over again, both papers, I couldn't understand how they would do that. And that's what they said exactly. It was mostly for aortic aneurysms. They thought that patients with established CAD would benefit from aortic aneurysm scanning. But I think we already have that answer from the MASS trial. So I didn't think that was as pertinent, but I'd love to at least see a sub-analysis of primary prevention patients and how that worked, because I still don't see that either. So I think they have obviously a lot of papers that they could write from this very large and well-done 45,000 person cohort. But those are the two I'd like to see, is the people who got scanned and then somehow try to propensity match them against the non-scan group. And I think we have to take in all of the things that Bob and others have said about the differences that those groups might entail. So it's probably not 50%, but maybe it's 20%. We'll see. And also see how, if you excluded the patients with established CVD, we know it becomes more cost effective, but they never wrote in what the event reduction was in either paper. So they said, yes, it becomes much more cost effective, which implies that it was better, but I don't know what that number is.
Yeah, great comments. And I just want to sneak in my own editorial remark that I think it's crazy that you have to pre-specify your primary endpoint. Okay, it makes sense, but to disregard death, MI, stroke, I mean, it's such an important and well-accepted composite endpoint. If the investigators had pre-specified that as the primary endpoint, this would be an entirely different discussion. We'd be hailing this as a remarkable, positive clinical trial. Doesn't make sense.
I couldn't agree more. And I have to say that I have never seen or even imagined that you could do a screening trial that would result in a 50% reduction in all-cause mortality among those who get screened. And we really need the details under that. We need to know what were the medications they were on, the whole picture, not just the questions that they were asking, because they had 10,471 people screened. That is a very large number. And there's a lot more research that needs to be done with this. I'm hoping, Dr. Maron, that Dr. Diedrichsen will work with you to publish some of those results per our after discussion. And I'm hoping that the common sense will prevail here, that even if you say, well, the composite endpoint of stroke, MI, and all-cause mortality is a 0.93 for the entire group. So 7% reduction across all people who were invited. And we don't know what that number was, other than the figure that he's now repeated in 3 interviews, one at European Society of Cardiology, one at Medscape, now the third one for the Right Care Initiative. So he obviously feels very strongly about this 50% reduction in all-cause mortality among those who were screened. And I'm just wondering what we can do to get that published.
It's up to Dr. Diedrichsen. He's holding all the cards, but we'd be happy to collaborate with him if he wants to.
Well, I could tell you, I mean, I saw the original paper and before it was edited by the New England Journal, and the title included semicolon 11% mortality reduction in patients aged 65 to 69 years old. And I was pretty sure that wasn't going to make it through the final edits of the New England Journal of Medicine, but I mean, at least he very strongly believed that it was a positive trial and has a very strong message to be told. So I can only imagine he might need help, but I think he can only imagine that he'd want to get out some of these other aspects to talk about, because I think they're important and meaningful endpoints, at least to learn from, to power future trials. If we're going to disregard this one or wait for the 10-year data, at least we can learn more about this, and it'll add a lot of information for power analysis, I think, if we wanted to do a trial in the US.
Well, Hattie, we're 4 minutes over. What do you think?
Well, David, I think you
I
did
think
an exceptional job today in your first discussion with Dr. Gulati, as well as your discussion of the DANCAVAS trial, and certainly want to thank everyone for it. Yes, there were some differences in the group. David, do you think if we did propensity score matching, does he have that data that he could maybe compare the groups a little better? Is that possible to go back in there and look at that? Or is it pretty much this is the only data we can get?
Yeah, I don't think they have much data on the control group for doing that kind of matching. It's a good idea, but I don't think he can do it.
Well, we're certainly delighted with the presentation today, and want to thank you for really putting all of these speakers on the docket today. It was certainly very enjoyable, and certainly a very good set of questions. Both chest pain as well as the advantage of additional screening are there. And so I think it was an excellent presentation that we had today. And I would at least personally like to thank all of the participants that joined us today, as well as all of our speakers. And I'll turn it over to Hattie for the final word.
I'd like to take down the next meeting slide because we have something really important to talk about. And that is, people keep saying we need more randomized control trials. We have such consistent observational evidence, plus this randomized control trial out of Denmark, that to me is just so compelling that we need to change public policy. We know these lives are being lost because people are not getting these screenings. And I just think it's urgent that we act on this information. And I'd love all of your perspectives on this. Especially Dr. Kaplan.
Well, I still think randomized clinical trial evidence is necessary and important, and that real world evidence from observational studies is a good complement to that, and that we're seeing an increasing number of high quality pragmatic trials, which also seem to be contributing to this. But I don't think that in the near term it's likely that you'll persuade people that that more randomized clinical trials are not necessary.
I'm not saying that we don't need more randomized control trials. What I'm saying is that the preponderance of evidence weighs heavily toward using the screening, particularly now that we have this large randomized control trial that screened 10,471 people So of those that were screened, their all-cause mortality was 0.5 hazard ratio, half the all-cause mortality. So I don't understand why that wouldn't be strong enough to act.
So Hattie, and by the way, I'm going to have to run in a minute, but maybe a good step would be to try to make that argument. Remember that the authors of this study concluded that the effect wasn't significant. I mean, that was the conclusion of the New England Journal paper, and so that you're suggesting a different.
But wait. They weren't looking at the people that got screened. They were looking at the people that had an invitation to join the study.
Yeah, and so what I'm getting at is that you would have to persuade the New England Journal of Medicine. In fact, maybe you should write a letter to the editor, but persuade them that looking at the subset is valuable, or is an appropriate way to consider these data. Because I think that the interpretation, even in the abstract, is not the same as yours, and so maybe that may be a good objective, to try to bring people along with your interpretation.
Well, it's the author's interpretation that he has said 3 times in 3 interviews that among those that were screened, they had half the all-cause mortality.
How did he just has to
But only
publish
among those that were screened.
He has to publish it. It's not published.
Right.
It's not real. So when
Yeah.
he publishes it in New England or Lancet or JAMA or Circulation or wherever he publishes it, nothing to do with New England. The paper's published. It's done. The next paper published, then I think you can make that argument. But we don't have that data. We have him. It's word of mouth. I can't even write that down in a paper. I'm not going to say that I heard him say this in a Right Care Initiative interview with David Maron. I mean, that's impressive, but it's not enough
But he
to
gave
publish.
the same. He said it 3 times. That's why I
He needs
invited
to
him
publish
to
it, though.
speak
That's
to
what I'm
us.
saying. Yep, but he needs to publish
He
it.
needs to
It's not
publish it
real
in
till he
writing.
writes it down.
Yeah, and it's this issue of the subset analysis, and I think you have to make the argument for the legitimacy of that, of looking at that subgroup. And Matt made the argument very persuasively.
We'll need to see that, and he'll write it down. Well, I'll reach out to him. I've worked with him before, so I'll ask him if maybe David and I and others maybe can, if he needs help to get some of these different subgroups out, and maybe they won't be accepted because the primary trial wasn't positive, or maybe they'll be looked at in some light based on a good robust analysis of how effective it is if you actually get a scan, and that might be important as well. So. All right,
Yeah,
I think we should conclude.
At this
Patty.
point, it is hearsay times 3, and hearsay times 3 doesn't make a difference over times 1. So we look forward to
How
that.
could it be hearsay? How could it be hearsay if it's the author, if it's the principal investigator emphasizing it and confirming it back to Dr. Maron? And Joe, you're muted.
No, I think he has to show the data and the argument.
Well, I wasn't going to. It needs to be peer reviewed, Hattie.
Okay, right. So
it needs to be peer reviewed.
Also, yeah. So the thing that was also confirmed was that it was statistically significant. The composite endpoint of reduction in stroke of 11%, death from stroke, and the composite of stroke, MI, and all-cause mortality reduction of 7%. So anyway, this is wonderful news that we've got a database that can be perused, and thank you, Matt, so much for being willing to reach out to the author, and thank you, Bob, for raising that important paper. That's what our statistics professor at UC Berkeley said, is that the difference between a 0.05 and a 0.06 p-value is the difference between 95% confidence and 94% confidence. It's not worth throwing out the results. So I think it's too bad that it's being the 5% all-cause mortality reduction across both age groups of those who were invited is still 94% confidence that that happened. So Bob, you've got great contacts who can possibly peruse this. I would love to have a supercomputer analysis of this data, because we should be looking at what medications have these patients been on. Because I asked Dr. Diedrichson in email, did they have access to all the modern medicines? And he said yes. So even though his initial prescription was aspirin and statin, they had access to everything American patients have access to. And so we don't know, what worked to reach that really impressive finding. And thank you for changing your schedule around, Bob, to join us today. It was really important.
It was great. It was a great session. So thanks. Anyway, it's good to see everyone. Bye-bye.
Be well, everyone. Take care.
Thank you. Have a great Robinska day.